Good morning, everybody. Thank you very much for giving me the opportunity to present my research today. This is a research project that I collaborated on a few years ago when I was a research assistant at UCL, and we wanted to investigate mentalizing abilities in eating disorder patients, and more specifically in bulimic patients, with a focus also on borderline personality disorder features. I will explain in a while why we cared so much also about this second variable, but let's start from the beginning, which is the definition of mentalizing. So what does mentalization or mentalizing mean? Well, in simple terms, we can say that mentalizing is the capacity to interpret one's own and others' behaviors as the result of their subjective mental states. For example, to interpret one person's actions and interactions with other people as driven by their thoughts, their desires, their feelings. In other words, mentalizing can be described as the ability to see ourselves from the outside as if we were assuming a more detached third-person perspective and see the others from the inside as if we were stepping in their shoes. And what is the reason why we care so much about mentalizing in psychology in general and today in regards to eating disorders? Well, because interpreting the world in terms of mentalizing states enables people to make sense of the social surroundings, to create a narrative, and therefore to navigate the social surroundings in a more meaningful and easy way. Mentalization abilities are not merely a cognitive function that is independent from the social environment. Conversely, mentalizing develops gradually throughout the first relationship with the significant others, and therefore in the context of attachment. This is also why during adulthood it's more easy to capture a breakdown in mentalizing in the context of significant relationships, for example, with a partner, a romantic partner. So whenever the attachment system is reactivated. The question is now, do we see impairments in mentalizing in eating disorders? This research question has been around for a while. Up to date, there are around 44 studies that have been conducted to analyze mentalizing in eating disorders, but only 5 of these studies have employed a sample of bulimic patients. These results do not give us a clear answer to whether mentalizing is actually impaired in eating disorders, and this is particularly true for bulimia nervosa, where results have been found to be particularly mixed, with some studies indicating impairments in mentalizing and others indicating bulimic patients to have close to normal or even superior mentalizing abilities. Therefore, overall in the literature, there is not a clear-cut answer to whether mentalizing is impaired in eating disorders and in bulimia specifically or not. Conversely, there is an heterogeneity of results. Now, this heterogeneity may be linked to different factors. First of all, we have to notice that mentalizing is a complex concept. It's an umbrella term. And as such, mentalizing has many different subcomponents. So it may be the case that the heterogeneity in the results found in the previous studies may be linked to an heterogeneity in the measures used for analyzing mentalizing. Maybe those measures were capturing different aspects of mentalizing that do not necessarily correlate in the same subjects. A second factor that is worth mentioning is the sample size. We know, of course, that it is always difficult to recruit a large sample size when dealing with clinical samples. And the third factor that should be mentioned is that there is an heterogeneity in the personality profiles of eating disorder patients themselves, so that even if certain patients are manifesting the same symptoms, those symptoms are playing different roles, have different meaning, and take place in different constellation of personality aspects. In this respect, a fairly new stream of research has tried to divide, to analyze the different personality profiles that can be found across eating disorder patients. And this researcher ended up with conceptualizing 3 different subcategories. The first one has been called as high functioning and perfectionistic, and it's mainly defined by the presence of a strive to accomplish and the need to be perfect, and generally does not present with personality disorders in comorbidity. The second subcomponent has been categorized as constricted and over-controlled, and tends to feel inadequate, inferior, or a failure, and to be dominated by anxious feelings. And these subcomponents tend to manifest comorbidity with the dependent and the obsessive-compulsive personality disorders, therefore with, again, anxiety-related symptomatologies. Now, there's a third subcomponent that is the one we care about today, that has been named as emotionally dysregulated and is dominated by the presence of impulsivity, the lack of control, the tendency to be overwhelmed with excessive feelings, and usually it's likely to present with a borderline personality disorder in comorbidity. Now, why do we care about that? Because the mentalization theory and impairments in mentalizing have been found and have been conceptualized in the context of the borderline personality disorder. In other terms, borderline personality disorder patients usually express impairments in mentalizing. So it may be the case that this heterogeneity in results that has been found in previous studies may be linked by the fact that certain patients had also some borderline personality disorder features, while others didn't. So to summarize again, the goals of this research project, they were befolded. On the one hand, we wanted to see whether bulimic patients presented with an impairment in mentalizing, and on the other hand, we wanted to assess whether borderline personality features influence the relationship between bulimic symptoms and mentalizing abilities. So to address our research questions, we employed a sample of 53 bulimic patients and 87 healthy controls. As I said before, one of the downfall of previous research was the presence of small sample sizes, and therefore we enlarged our sample size to exceed the number indicated by power analysis in our study. We then had 2 sets of measures, one for assessing psychopathology and the second one for assessing mentalizing. In regards to psychopathological symptoms, we assessed eating disorder symptoms using the eating disorders examination questionnaire. We evaluated BPD symptoms using the Zanarini rating scale for borderline personality disorder. And finally, we assessed the general well-being of patients using the depression, anxiety, and stress scale. In regards to mentalizing, as I said before, mentalizing is a complex concept that has different subcomponents and has different, it can express in different behaviors, in different manners. Therefore, since we wanted to have a comprehensive picture of the mentalization abilities of our sample, we decided to use 3 different measures for analyzing mentalizing. The first one is the differentiation and relatedness scale. The second one is the reflective functioning questionnaire, and the last one is the reading the mind in the eyes test. I will explain those tests in the following slides. The first measure that we used for analyzing mentalizing was the differentiation and relatedness scale. This is a measure that enables to assess the level of object representations and therefore the level of integration, differentiation, and relatedness of self and significant others. Participants are asked to give 3 open-ended descriptions of the self, the mother, and the father, and eventually 2 independent examiners score those descriptions on a 10-point scoring system ranging from 1 to 10, where lower scores indicate more simple object representations, where the boundaries between the self and other are often compromised, where the sense of relatedness is often immature, and the descriptions tend to be polarized towards very negative or very positive aspects with stereotypical adjectives. Conversely, to the opposite end of the scale, we have higher scores, which indicate the presence of more complex object representations, more nuanced and coherent descriptions, a higher tolerance for ambivalence, and a more mature sense of relatedness. These measures gives us with three final outcomes that are a score in regards to the self, one in regards to the mother, and one for the father. The second measure that we used for analyzing mentalizing was the reading the mind in the eyes test. During this test, participants are given with 36 pictures presenting with different facial expressions and specifically the eye area of the face. And participants are asked to report which of the feelings better described the facial expression, the expression reported in that specific picture. So for example, if we look at the first picture of the test, participants are asked to say whether the eyes of the person are expressing playful or a comforting or an irritated or a bored state. In this case, the correct answer is playful, and so on for the other examples. The third and last measure used for analyzing mentalizing was the reflective function questionnaire. The questionnaire is made of 54 items. Example items are people's thoughts are a mystery to me, or I always know what I feel, or I don't always know why I do what I do. In other terms, items analyzing the reflective functioning of participants. Participants are asked to rate each item on a 6-point Likert scale, ranging from I strongly agree to I strongly disagree to the content of each item. The questionnaire has two subscales or two factors. One has been called certainty and the other one has been called uncertainty, and they enable researchers to look for the two possible psychopathological degeneration of mentalizing. On the one hand, hypermentalizing, and on the other hand, hypomentalizing. Indeed, lower scores on the certainty subscale are indicative of the presence of hypermentalizing and therefore the tendency to interpret the word hyper-rationally. Conversely, higher scores on the uncertainty subscale are indicative of hypomentalizing, therefore the tendency to interpret the social surroundings lacking of mentalizing terms. So this is our results. First of all, let's start from the descriptives. As we can see, bulimic patients and healthy controls were found to be equal in terms of BMI and age. Conversely, the bulimic sample was found to have higher eating disorder symptoms, as expected, to report a general lower well-being, as indicated by lower scores on the DASS scale, and also to report significantly higher level of borderline personality disorder symptoms. This is what we found in regards to mentalizing. The results were pretty clear-cut in the sense that bulimic patients were found to have worse mentalizing in all the scales that we use for analyzing disability. As we can see, specifically, bulimic patients were found to have less complex object representations as indicated by their descriptions of the self, the mother, and the father. They were also found to exhibit deficits in recognizing other people's emotion through facial expressions, as indicated by results, lower scores in the reading the mind in the eyes test. And finally, they were found to have higher scores on the certainty subscales of the reflective function questionnaire and lower score on the uncertainty subscale, indicating overall that bulimic patients had a tendency to hypomentalize, therefore had a tendency not to interpret the social surroundings in mentalizing terms. So we were able to find an answer to our first research question, which was whether bulimic patients would show worse mentalizing compared to healthy controls. However, we were not able to directly control for borderline personality disorder symptoms in this analysis, which corresponded to our second research question, since our clinical sample was found to have consistently high borderline personality disorder symptoms. Indeed, only 7 subjects scored below a clinical critical cutoff for clinical concern on the ZAN-BPD scale. However, we found some significant correlation between certain measure of mentalizing and the level of borderline personality disorder symptoms. So we decided to run some bidirectional models between bulimic symptoms, these measures of mentalizing, and borderline personality disorder symptoms as mediator. What we found is that indeed the mediation model was found to be significant, and the indirect effect between bulimic symptoms and mentalizing as mediated by borderline personality symptoms was found to be significant. However, even including the mediation, the borderline personality disorder symptoms as mediator in the model, the direct effect between bulimic symptoms and mentalizing remained significant. Therefore, we concluded that eating disorder symptoms and bulimic borderline personality disorder symptoms may contribute independently in determining low mentalizing in our population. So overall, the results of this study indicated that indeed bulimic patients tend to have an impairment in mentalizing. Borderline personality disorder features were found to only partially mediate the relationship between bulimic symptoms and mentalizing. Therefore, they do play a role in determining lower mentalizing abilities in this population, but they do not comprehensively explain the presence of low mentalizing in this population. Overall, our results lend empirical support for the hypothesis that low mentalizing may be key in the etiology and maintenance of bulimic symptoms, and therefore they also lend empirical support to the need for treatment protocols aiming to implement mentalizing abilities, such as the mentalization-based treatment that has been tested in this population in the past few years. This is the list of references that I have been citing in the previous slides. I would like to thank you for listening to me, and I would like to thank the people who were my supervisors when I was doing this project, this study, who are Peter Fonagy, Paul Robinson, who should be here today, and Patrick Luton. I'll be happy to answer any questions. I'm sure there's a way to contact me during the conference, and if not, or for any other reason, this is my email address. I included here some additional data with the raw scores of participants in all measures of mentalizing, in case you have questions in regards to that. Here are also some additional analyses that we ran to analyze the relationship between eating disorder symptom severity and mentalizing, which were found not to correlate. So thanks again for listening to me, and I hope to see you soon. Have a great conference.